Hi, everyone. Thanks for joining us for tonight's webinar, PKDCON Follow-Up, Your Questions Answered. We look forward to answering your questions with the help of our panelists. I'm Elise Hoover, the Director of Research at the Foundation, and I'll be your host. Also joining me from the Foundation is Shauna Eichenberg, who is available to help you with any technical difficulties. Next slide. All attendees will remain muted throughout the presentation to ensure good audio quality. We are recording the webinar and we'll post the recording on our website within the next few days. If you have any questions during the presentation, please type them into the question box located in your control panel on the right side of your screen. Next slide. This session is designed for informational purposes only and is not intended as advice on the specific treatment or diagnosis of your PKD. As you listen, if it sparks questions for you regarding your own disease journey, please speak with your doctor. Next slide. Okay, and next slide again. Please take a moment to review the financial relationships of our panelists. Next slide, please. As a reminder, tonight we'll be hearing from our panelists as they address your unresolved questions from the PKD Connect conference held virtually in June. Some of you submitted questions prior to the webinar, but you can also submit them live here and now, and we'll do our best to answer them as many as we can tonight. All right, next slide. So tonight we'll be hearing from 3 individuals who work closely with patients with PKD. We're super fortunate to have them this evening. Thank you for joining us. I want to start by introducing Diana Bruin. Diana is a specialized renal dietitian with a focus on proactive nutrition for PKD. She brings over 13 years of nutrition experience and expertise to the table, with more than half of that focus in the renal space. Her superpower is translating complicated science into understandable concepts and moving those concepts into action with doable dietary changes. Diana is a pioneer in the plant-focused ketogenic diet for PKD and also specialized in plant-based diets for chronic kidney disease, oxalate management, and recipe and menu development. Also with us is Dr. Erin Hartung. She's an attending pediatric nephrologist at Children's Hospital of Philadelphia, or CHOP, and an assistant professor of pediatrics in the Perelman School of Medicine of the University of Pennsylvania. Her clinical and research focus is in PKD, particularly autosomal recessive PKD. She co-directs the Combined Kidney-Liver Program at CHOP, which specializes in the care of children with ARPKD and other genetic kidney liver diseases and ciliopathies. Her research aims to accelerate the development of new treatments for ARPKD through observational and database studies to better define the natural history of the disease, and also through imaging studies to develop new biomarkers of kidney and liver disease progression. Dr. Hartung serves on the Foundation's Scientific Advisory Committee and our PKD and Children Council, and was the lead author of our ARPKD Patient Handbook. She also serves as the director of the Pediatric Nephrology Fellowship Program at CHOP, where she helps to train the next generation of pediatric nephrologists. And our third panelist today, she's not on camera, but she is with us, Dr. Terry Watnick. She is the Joan B. and John H. Sadler Professor of Nephrology at the University of Maryland School of Medicine. She received her medical degree from the Yale School of Medicine and completed her training at Yale New Haven Hospital. Dr. Watnick moved to the Johns Hopkins Hospital, where she received clinical and research training in nephrology. Dr. Watnick has a laboratory that focuses on understanding the factors that cause aneurysms in AD-PKD. In addition, she has been an investigator in several multi-center clinical trials recruiting patients with AD-PKD, including TEMPO, REPRISE, and TAME. Dr. Watnick is the principal investigator of the NIH-funded Maryland PKD Research and Translation Core Center, as well as the PI of the central coordinating site for that program. Dr. Watnick previously served as the chair of the Foundation Scientific Advisory Committee and was a member of the Board of Trustees. And then I'm Elise Hoover. You've met me already. That's enough for me. Let's get started with some questions. All right, our first question is for Terry. Dr. Watnick, could you remind, for those of you who don't know, what is tolvaptan and what are some tips for coping with the side effects?
Okay, can everybody hear me okay?
Yes, we can.
Okay, so tolvaptan inhibits a hormone called vasopressin, which is a hormone that we all make. That hormone works through a second messenger, cyclic AMP. And it has been shown in the laboratory that cyclic AMP may specifically cause ADPKD cells to secrete fluid, which would go into the cyst, and also to possibly accelerate cyst growth. This receptor, the vasopressin receptor, which tolvaptan is inhibiting, is only present in the kidney. So by blocking that receptor, the idea is that you block cysts from growing and from having fluid secretion. And as I guess everybody knows, tolvaptan was studied in 2 very large clinical trials. And those studies showed that the drug, the first study showed that the drug slowed the growth of kidneys in a 3-year study. And both studies suggested that tolvaptan slowed the decline in kidney function by about 20 to 30% in that range, which is similar to what has been seen with ACE, angiotensin converting enzyme blockers, and ARBs and other kidney diseases. So because tolvaptan blocks the effects of vasopressin, which causes the kidney to reabsorb water, the main side effect that patients complain about is a lot of urination. Okay, so sometimes, at least my patients will tell me that they urinate about once every 45 minutes to an hour and a half, which can be a lot. They also get up at night quite a bit. And the last side effect, which isn't something that you may feel, but is, of concern, is that in about 5% of patients who were in those studies that I mentioned developed elevations in their liver function tests. So in terms of mitigating the frequent urination, I think one thing that, a couple of things that I think need to be considered is, one is when you take the medication. Okay, so if a lot of people complain that they're really exhausted because they're essentially getting up at night like 3 times or maybe even more to urinate. So one way to address that is just by making sure that you don't take the second dose very late in the afternoon. So I usually advise my patients to take their first dose by like 6 or 7 in the morning, and then 8 hours later, it's kind of the middle of the afternoon. If you take that second dose at 8 o'clock at night, you're basically going to be getting up all night. Mm-hmm. So that's one point. And the second point is that it is, you need to use the lowest dose of tolvaptan that provides blockade of the V2 receptor, right? So not everybody needs to be on the highest dose. And so that's another way to get at it. And what I usually do there is I measure the concentration of the urine first thing in the morning, and I titrate the medicine based on that, and I use the lowest possible dose that I can. So I don't know if that's a very long-winded answer, but I don't know if there are any follow-up questions.
That's great, Terry. Thank you. Yeah, no one has follow-up questions. Mm-hmm.
Yeah. No, I was just going to say, in terms of the liver toxicity, I'm not sure how to mitigate that. I don't think we understand it well enough to know. It isn't really related to the extent of polycystic liver disease. So that there it's unclear, but we definitely, according to the REMS program, liver function has to be followed really closely.
Yeah, anyone who has a tolvaptan prescription knows that you have to go in for pretty frequent blood tests, so to keep you safe, although I'm sure it's inconvenient. Thank you, Terry. Yeah, if there are any other questions about that, please go ahead and put those in the question box. But Diana, so, for patients who are taking tolvaptan, they have a lot of frequent urination and also thirst. Is there such a thing as drinking too much water for a person with ADPKD, whether on or off of that medication?
Good question. Their short answer is yes, but a little bit more to unpack there. As was just being discussed, you want adequate hydration so as not to signal that pathway, that vasopressin pathway that contributes to the cyst progression. But for each person, there is a different amount of fluid that they need. General recommendations is about 2 to 4 liters. Most people aim for about 3 liters, but of course, other factors go into how much you drink, what medications you are on, like if you're on a diuretic or certain blood pressure medications or tolvaptan, you might have different hydration needs, but also if you have any other comorbids or any other disease states, you might have different hydration needs too. And of course, if you live in a hot climate, if you exercise a lot, so there's different factors that go into how much fluid you need. But there is a risk of having too much fluid. And what happens at that point is the levels of sodium in your blood can go low. And that's not a good scenario. There's definitely some side effects connected with that you don't want to have to deal with. And so that's something that every time that you go into your doctor for your labs, they're going to look at that as part of your panel. So consume the same amount of fluid that you normally do, and definitely those readings will tell you if you have too much. So a lot of different responses to that question.
That's perfect. Dr. Hartung, can you tell us your opinions on screening a child for PKD?
Yeah, so I think the answer, it's different for autosomal dominant versus autosomal recessive. So in dominant, there's no clear guidelines to say that you should or shouldn't. And so I always discuss the pros and cons with the families that I take care of. So, there are certain potential benefits, like, maybe being able to be more careful about monitoring their blood pressure or monitoring for protein in the urine, things like that. But at the same time, you can be careful about all of those things without necessarily establishing a diagnosis in childhood. As you know, that the drug we were just talking about, tolvaptan, is only approved for use in people 18 and over. And so if we make a diagnosis of PKD in childhood, we're essentially, checking blood pressure, we're maybe looking for protein in the urine, maybe doing labs once in a while, but it doesn't necessarily often affect their medical care as long as they're not developing things like high blood pressure or protein in the urine. And so I leave that decision up to families, because the cons also involve, giving a child a medical diagnosis that maybe they are not prepared to handle, potential insurance concerns, and medicalizing a child who otherwise that you would like them to, be a kid and live their lives. So there are pros and cons, and so I think that's a very individual decision. When it comes to AR-PKD, I do recommend it just because that is a different scenario where there are complications that can be expected during childhood. There's things that we would want to be looking out for, in particular high blood pressure, but other issues as well, like decline of kidney function and things like that, that could only be found by doing things like blood work that wouldn't be part of a well child's usual care. So I usually do recommend for children, if they have a sibling with AR-PKD, that we usually get an ultrasound on the siblings just to make sure. But again, the age at which they do that, that's also, there's no strict rules, and you can discuss that with your doctor.
Okay, speaking of screening, Dr. Watnick, can you tell us who you think should be screened for brain aneurysms?
Yes, okay. So if you look at all of the data, individuals with autosomal dominant polycystic kidney disease are overall, for all comers, at about 4 to 5 times the risk of developing a brain aneurysm compared with the general community. However, if you look at people who have a family history of PKD and aneurysms, that risk goes up an additional 4 to 5-fold. So definitely, we recommend screening anyone who has a family history of a brain aneurysm. Okay, and sometimes I'm liberal about that. So if someone says, oh, someone in their family had a sudden death event, they died suddenly, and no one was sure, but it could have been a brain aneurysm, I will screen those people. We also recommend screening people who have a profession where if they had a sudden brain aneurysm rupture, it would affect the lives of a lot of people. And the example that we frequently use, but it's not the only one, would be like an airline pilot. Also, we screen people who have had an aneurysm in the past and have had it treated. And lastly, if people are nervous about the diagnosis and they want to know, then we can also screen them as well.
Excellent. We just got a question for Diana about diet. Could you talk a little bit about reducing potassium in the diet? Often patients are told to stay under 2,000 milligrams, but is there a lower limit? What should you keep in mind when looking at doing that for your diet?
Another good question. So first off, not everybody with PKD and even CKD needs to restrict potassium. So I think the first thing that is very important to know is if talking with your doctor, if you have a history of elevated potassium, if you're on any medications that could cause potentially you to have elevated potassium, and also if you are at risk. If you are, have that conversation with your doctor, and from there, a potassium restriction you can be educated on it, and then also helped by a dietitian to put it in place. Generally, a potassium restriction is between 2,500 and 3,000 milligrams of potassium, which is a fair amount of potassium. But what I do really want to say is that if you don't medically need a potassium restriction, your kidneys are still filtering potassium, actually limiting it will do you no good, because you are limiting foods that are very beneficial to you with PKD and your kidney health. In fact, it's recommended that you have upwards of 4,700 milligrams. And I know I'm throwing out some numbers there, but for you numbers folks, hopefully that will help. And why is that so important? Because higher intake of potassium-rich foods are associated with better blood pressure control, but also associated with better fiber. And I mean, I could go on and on, the list of positive aspects. So just to recoup and to summarize, first find out if you medically need a potassium restriction or one is recommended. And then if you don't, actually focus on potassium rich foods is beneficial for you. So.
That's fantastic. It's a tough balance. Let's talk a little more about some of the other manifestations of the disease. Dr. Hartung, could you talk about congenital hepatic fibrosis and what you see in your patients?
Yeah, so for families that are affected only by ADPKD, you may be probably less familiar with this, but congenital hepatic fibrosis is the liver complication that can develop in people with ARPKD. It is a condition where the liver develops, it becomes stiffer than it should be. And along with that, people can also have problems with the bile ducts, so they can have some dilations in the bile ducts that can predispose them to bile duct infections called cholangitis. And then that portal hypertension, the liver fibrosis can lead to a condition called portal hypertension, where the blood flow that is supposed to go from the spleen and the intestines, all of that blood flow normally flows through the liver. And if the liver is stiff and doesn't allow that blood to flow through properly, then that blood can back up into the spleen and the intestines, and it can cause certain complications such as enlargement of the spleen, which can lead to low blood counts because the spleen kind of eats up certain blood cells. And then it can lead to dilated veins, mostly in the esophagus and stomach. So that can lead to a complication called esophageal varices. With the, just like everything with ARPKD, everything can be very variable. So there's a huge range, a huge spectrum of severity. Some people will maybe have some abnormalities that are visible by ultrasound on their liver, but have no symptoms at all and may never develop symptoms ever. And then there's some people who can have very severe complications and require procedures to stop bleeding, or sometimes even procedures to divert the blood flow through the liver. And in a small percentage of patients, probably less than 10% of patients, maybe even a liver transplant. So it's very variable, and I think you can ask your doctors to look for things like low platelet counts and large spleen. Those are often the signs that portal hypertension is developing.
Okay. Dr. Watnick, some patients may see cysts on their liver. How do they know if it is polycystic liver disease? And can you tell us a little bit more about that?
Okay, so polycystic liver disease just means more than one liver cyst. So I think 80% or more of individuals with autosomal dominant polycystic kidney disease will have cysts in their liver. So it's the most common manifestation of autosomal dominant polycystic kidney disease outside of the kidneys. So very severe polycystic liver disease happens in a smaller percentage of people, maybe 5 to 10%, and that tends, not 100%, because as Erin mentioned, these things are variable, but tends to occur in women. Okay, and unlike congenital hepatic fibrosis, liver function is for the most part not affected. And what you get instead is just the effects of having a huge bulky liver. Very rarely does this also go on to require a liver transplant. And again, it's usually due just to the sheer bulk of the liver. And again, rarely, it can also cause portal hypertension, but it's again rare. It's a difficult problem because again, we don't really have a highly effective medication that's available. So it's just a thorny problem to deal with.
And Dr. Watnick, we know there's an association between estrogen and polycystic liver disease.
Right.
We have a question for someone asking about your advice about exposure to estrogen, especially for a young girl who's looking at birth control options. What should they keep in mind?
Yeah, so that's a great question, and I don't think that we have, there's no studies been done on that. What we do know is that because severe polycystic liver disease tends to occur in women, it's been assumed that it's due to estrogen exposure. And so the one study that has been done is looking at postmenopausal estrogens in women, and women who were placed on postmenopausal estrogen, and that's no longer in vogue, were more likely to develop severe polycystic liver disease. But now oral contraceptive pills, the amount of estrogen in those is far less. And to my knowledge, that has not been looked at formally. So I think if someone does have severe, you see a young woman and she does have fairly severe polycystic liver disease, I just recommend that they be on the lowest dose pill possible. But also then getting pregnant is an exposure to hormones as well. So you kind of have to balance those considerations. But I think it's a study that should be done. Is to look at estrogen exposure in young women, who are on like the lower dose estrogen containing pills, but hasn't been done yet. So I hope that I answered the question.
Yeah, thank you. Diana, we've had some questions coming in about vitamins and supplements. What's your advice regarding that for patients with PKD, specifically vitamin C, curcumin, or folic acid?
Yes. So let's start with vitamin C. So vitamin C it's essential. You need it every day, basically meaning that your body can't make it, so you have to eat it. But concerning supplementation, that's a different story than getting vitamin C from food. And so my general recommendation is to not supplement with vitamin C. And here's why. So high doses of vitamin C, if you're thinking like airborne or those tablets, you don't absorb it all, so it's not beneficial to you. But also high doses of vitamin C, when vitamin C is broken down in your body, one of the leftovers from it is something called oxalates. And what you need to know about that is a high number of those in your diet puts you at a higher risk for kidney stones, which unfortunately with PKD, there is a higher risk there. But if you're just looking at a general multivitamin or something that has vitamin C in it as part of your general vitamin, those levels are totally okay. A good rule of thumb for me is 250 or less a day if someone has it in their supplements, and that's pretty conservative. My overall recommendation is it's much better to get it from food. Absolutely. So, just for example, for all you veggie lovers out there, a half cup of broccoli is gonna get more than 50% of your vitamin C and a lot of other good things. So definitely get it from your food. Don't go for big supplements, and you're never going to get too much vitamin C just from what you're eating. Let's see, what was the next one? The next one was turmeric.
Yeah.
Okay, so turmeric, that's a hot topic these days. There's actually been some pretty good work on turmeric and cyst growth and anti-inflammatory properties. So what I want to say about turmeric is the actual component in turmeric that is beneficial is something called curcumin. And that, if you are going to supplement, first, make sure you talk to your doctor and let them know everything that you're adding or changing to your diet. But if you are going to supplement, do not do it with turmeric. You want to do it with the actual curcumin because that's the beneficial part. And definitely there's different levels that are beneficial. And here's why. Turmeric, we're back to those oxalates, is very high in oxalates. Of course, some in your cooking, absolutely fine, quite delicious if you're making a curry, but you just don't want to add in all of that to your diet because the amount that you would need to get those special anti-inflammatory properties and protective measures would be so much. First of all, wouldn't taste good. Second of all, you're just adding tons of oxalates. So I hope I didn't talk you guys in a circle there, but concerning turmeric, yes, safe to supplement with the curcumin. Don't overdo it with the actual turmeric. But again, talk to someone if you're confused, if it would benefit you. And then the last one was folate.
Folic acid.
Folic acid.
Mm-hmm.
Okay, so with folic acid, that really depends on you, what your diet is, but also what your kidney function is. So there's different layers in there. First, always make sure that you can get it from your diet. That's the best case. But as kidney function declines, if it does decline, there is a need, and that's part of the B vitamins, the folic acid. There is a need to supplement frequently based on what you are actually consuming to meet your needs. So overdoing it is not going to benefit you, but supplementing to meet your needs might be needed. I know those are very general recommendations. A lot of times when I am working with someone who is later stage kidney disease because of the different processes, we do look at including a B complex vitamin. But that's something to talk with your professional, your healthcare team about if you would benefit from it. And just remember, supplements, they're not, an underlying good diet is the best avenue, and then supplements fill in the gaps. They are not the in addition to. So really look at, will it benefit me and do I need it before you start adding different things in.
That's fantastic. Thank you. We had a follow-up question about estrogen, but in the diet, what advice would you have for eating soy and the concerns about getting estrogen through that or other foods?
Yeah, no. So soy and flax are the two big things I get asked about. So a lot of the women who I have worked with who also have cyst involvement in their liver, they want to know. And here's the reason, because there's parts of in that soy and in the flax that's called phytoestrogens, meaning that they essentially could function as estrogen in the body. However, I do not restrict those aspects in the diet, and I don't generally recommend it. I don't see a benefit to it unless there are very enlarged cyst within the liver and big liver involvement. Then, similar to what was mentioned earlier concerning birth control, definitely go on the more conservative route. But completely cutting out those pieces of your diet is not going to benefit you in the short or long run concerning the liver.
Thank you. All right, we've had some questions about what to expect post-transplant, and I wonder if we could start with Dr. Hartung talking about pediatric cases. We've had kidney or liver transplants, and then we can go to Dr. Watnick. What kind of long-term health effects of immunosuppressive medications and other complications can people expect?
If you don't mind, I'll have Terry go first. My dogs are going a little crazy because my family just got home, so I'll let Terry go first.
No problem.
Okay, so yeah, so I mean, obviously when you get a transplant, you're on medications that suppress your immune system. So in the long term, that is really what you're getting side effects of immunosuppression. So, you know, one of the things we see very frequently is an increased risk of skin cancers is a big one. Okay, so I always tell my patients before, like, you know, stay out of the sun, make sure you wear sunscreen, because even when you don't have a transplant, that risk of all of that sun exposure over a long time is cumulative. And then once you're immunosuppressed, it can really become a problem. I guess in the longer term complications, obviously you're at increased risk of infection. And we've seen now with COVID, which is something I wouldn't have ever talked about before, is that, you know, in the case of COVID, the vaccinations don't work as well, you know, because obviously you're on medication that's suppressing your immune system. It's also suppressing your ability to develop antibodies to different vaccinations. I think those are the main ones that I can think of. I know, Elise, and the question that you mentioned was post-transplant erythrocytosis. And I don't know if you wanted me to kind of talk about that as well.
Sure, yes, please.
Okay, so what that is in a small, it's actually a pretty small percentage of people, that fraction is decreasing. The hematocrit gets a lot higher than it should be. Okay, and with the use of ACE inhibitors and angiotensin receptor blockers, actually the amount of post-transplant erythrocytosis that we see is much less than it used to be. So I don't view, it happens for sure, and there's certain risk factors for it, but I wouldn't put it at the, it's not as common as some of the other things I just mentioned.
Thank you. Dr. Hartung, anything to add for pediatric patients?
Quieter here now. I think very similar considerations in pediatrics. We also counsel our patients to be very careful about avoiding sun and sunscreen. There are, and you know, again, looking at potential, there is a small increased risk of other cancers as well, like post-transplant lymphoproliferative disorder, which is a variant of lymphoma. And that's something your team will be looking out for. It can be caused by the virus EBV, which is the same virus that causes mono, but people who've had transplants get screened regularly in their blood for that. In terms of infections, there are, like Terry mentioned, certain immunizations you may need extra doses of, so including the COVID vaccine actually. So it is recommended to get a third dose, not as a, not strictly speaking a booster, but it's basically a third dose to complete your primary series, because you may not have responded to the 2 doses. And then there are certain vaccines where, you know, ones that you may have had before that you need repeats of, so things like hepatitis B or things like that. It's important to stay up with your flu vaccine every year and things like that to avoid infections. The only other specific thing with children related to transplant and immunosuppression is steroids and their effect on growth. So most pediatric protocols, it used to be that steroids were given to everybody, and over the years we are starting to use just lower doses of them to try to minimize some of those effects on growth. And then in certain select cases, if you have a very well matched transplant kidney and you're at lower risk for certain complications, there are even in some cases the option to try to do a regimen that doesn't include steroids, but that all has to be discussed and it has to be safe for you.
Diana, any considerations you would advise for post-transplant patients regarding nutrition, food preparation, recipes?
Yeah, it's a little bit, actually, it's a lot of shift from pre to post-transplant. So right after transplant, you go through an acute phase, which is literally that right after transplant. And, you know, the biggest concerns there are recovering from surgery, healing, and making sure that there's no exposure from your food for an infection. And that's usually handled, that education and work is usually handled by the dietitian with the transplant team. And then once you finish that phase, which is usually about, I think, 6 to 8 weeks, don't quote me on that though. After that, it's really about maintaining a healthy weight. A lot of folks have gone from dietary restrictions to no restrictions, and guess what? That hunger comes back, but also you're on steroids, so you're even hungrier. So post-transplant work is all about, there are some side effects with the medications, working on that, making sure that you are eating a diet that promotes heart health, and then also making sure that you maintain a healthy weight. And that's usually the focus after transplant. Of course, each person is individual, but that's a lot of the work that I have done with people after transplant. So a little bit different. So a nice pendulum swing though.
We also just got some questions.
Oh, I
Yeah,
just wanted to just comment on the use of steroids in adult transplant.
Please.
Just to say that there are, you know, there are some centers that use steroids in all people, and then there are some centers that do not. So for example, our center at University of Maryland, we do not, that people generally don't get steroids, whereas at other places I've been, they do. So there's some difference there. And, you know, when you are on steroids, and even if you're not, there's a risk of developing diabetes post-transplant. So, you know, if obviously cutting down on steroid use can impact that as well.
Yeah, well, thank you. Didn't want to miss that. We had some questions also about nephrectomy. Dr. Wadden, could you tell us a little bit about what you've seen in your patients as far as timing? Before transplant, during the procedure, afterwards, what do you usually see? What do you recommend?
So again, it's very center dependent, right? So there are some centers that feel very comfortable removing kidneys at the time of a transplant. So that usually is done when you have a living donor. Okay, because if you remove them before, then you're going to be on dialysis. So, and it depends. There are some centers who do not feel comfortable removing kidneys at the time of transplant because, you know, there is always a risk that as you take the kidneys out, if a cyst ruptures, there's inflammatory mediators that can be released and you can have low blood pressure. And for centers who do not feel comfortable, there's you can either remove the kidneys before, and that again is usually there's a living donor. And someone has a living donor, so you remove the kidneys beforehand, the person will heal up and then they can get a transplant. But the disadvantage there is that people will usually have to be on dialysis. You know, it can be from 6 to 8 weeks. And then there are centers who remove who feel more comfortable removing the kidneys post-transplant. So I think it can be done all different ways. It depends. I think the advice is to make sure that whatever you do, that your center has done a lot of whatever it is that they're recommending and they feel comfortable with it.
And Terry actually has a follow-up question for you. Not all patients will need their native kidneys removed, right? From what I hear from my patients' parents, some people have been able to have transplant without having their native kidneys removed.
That is true. So the indications that I think most there's consensus on in terms of removing the native kidneys is, one, if the kidneys are so big that the surgeon feels that there's no room for the transplant. Second would be recurrent infections. So if someone, I have patients who have, will be having frequent urinary tract infections and with resistant bacteria. So definitely you don't want to be immunosuppressed and have those kidneys left in. And the third indication is, recurrent bleeding or gross hematuria. And last of all, there are people who just have a lot of pain or who are just so uncomfortable that they want their kidneys out. So, but it is true, if someone is not having any trouble, they don't have infections, their kidneys aren't all that big, then yes, you can leave the kidneys in.
And then I'll answer the same question for ARPKD. So, in children, especially if they're quite young, it is more common than not to need to remove the kidneys, just because usually the kidneys are quite large relative to the size of the child's abdomen. And so usually even just to be able to make room for the transplant kidney in the belly, the native kidneys usually do need to be removed. And again, there's variation. Even at our center, the surgeons will decide on a case-by-case basis, and it all depends how big the kidneys are, how big the child is. On rare occasions, people have been able to get transplanted without the native kidneys being removed. And then there's been times where we've done it, as Terry mentioned, where it's been done like 6 or 8 weeks in advance with a period of dialysis in between, and then sometimes at the time of transplant as well.
Thank you both. And the foundation also has a resource. It's called PKD Find a Clinic. If you are looking for a clinician, newly diagnosed, looking to change your clinician, we try to collect information there that we think would be of interest to patients, including their preference for timing of nephrectomy, steroid use, participation in clinical research. So if you'd like to check that out, it's Find a Clinic on our website. Okay, I have a question here. Could you, maybe Dr. Watnick, tell us, is GFR the same as percentage of kidney function? How should patients think about their lab values?
Okay, so first of all, I want to say glomerular, well, I think that when you get your labs drawn, okay, your labs are followed, your creatinine is usually drawn, and accompanying that is an eGFR value, and that is estimated GFR, okay? And that what they are doing there, because sometimes I get questions like people say, but my GFR is this and creatinine is something else. The estimated GFR is directly related to the serum creatinine that's measured. So what happens in the lab is they take the creatinine, the sex, the age, and plug that into a formula, and that gives you an estimated GFR. Okay, so in a way, if you think of a GFR of 100 as being normal, then yes, the estimated GFR in a way is giving you a percentage, but it isn't. The estimated GFR is not really an independent variable. It depends directly on the creatinine. Okay, also to note is that your GFR, even if the creatinine were to stay completely stable, declines with age because of that age term. So an 80-year-old with a creatinine of 1.2 may have a very reduced GFR, whereas if you're 20 and have a creatinine of 1.2, your GFR may be, in the relatively normal range. Mm-hmm. The other thing to know is that, and this is a controversial area, there is a term for modifying that GFR based on someone's race. So for example, for creatinine of 1.2, the estimated GFR may be different if you're African American versus if you're white. And that has been quite controversial. That fudge factor value was based on older studies, and I think the concept of race is really changing now. So that is being debated now, and that may change in the future. Aram, do you want to comment on that for kids? I don't know.
Yeah, so for kids, the one thing to know is that the equations that we use to translate that creatinine value into an estimated GFR are completely different in children than they are in adults. And so if you get a lab report done, say at a LabCorp or Quest or somewhere that's not a pediatric specific place, and if it has a GFR number on there, that is likely to be incorrect, because usually they just do it, they plug the child's age into an adult calculator, but that doesn't mean anything. And so if you want to know your child's GFR, ask your nephrologist to calculate it for you. The variables that go into a child's GFR calculation, depending on which calculator you use, include age, gender, and height. And the reason for the height factor is that creatinine, because it's made in the muscles, the creatinine number naturally increases as a child grows. So a little baby's normal creatinine might be 0.2, and a big 18-year-old boy's creatinine might be 1. And there is a natural rise in creatinine that happens with age, and that's related to the growth of the person and the muscles. So that height factor tries to account for that.
Thank you both. Well, we're almost up on time. Thank you so much to the panel for answering these questions. Any final remarks before we sign off? Diana?
Just thanks for coming, and also happy almost PKD Awareness Month.
Dr. Hartung? Any final remarks?
Yeah, again, I'd just say thanks for coming, and I think it's great that people are taking the time to stay informed. And I think like we said at the beginning, everything that we're saying is general advice, and but I think taking these things back to your care team and seeing what's right for you, I think that's always going to be the most important thing.